ठीक है. So topic for today
कोई
is
आया नहीं? अच्छा.
PRP in reproductive rejuvenation. After quotation,
हाँ.
so platelet-rich plasma is a biological product obtained from autologous fresh whole blood after centrifugation, which contain more than 5 times higher concentration of platelets above the normal value, and as well the growth factors in proportion. So the two lines about the history of PRP. PRP was first developed by hematologists in the 1970 as a blood transfusion product for the treatment of thrombocytopenia. Currently, platelet-rich plasma, commonly known as PRP therapy, is widely used for the treatment of vast majority of diseases. That's a cardiac, pediatric, gynecology, and many other specialties they are already doing, and other new ones are trying and recruiting in their medical protocol. So why the questions come, why platelet-rich plasma is becoming more popular as regenerative medicine? So because of its non-operative treatment option and easy to operate for a broad spectrum of medical disorder. So now I'm dedicated today for the reproductive rejuvenation. So I'm discussing about that only. That is the platelet-rich plasma therapy in female and male infertility. It's being widely used to address following issues in female infertility for the poor ovarian reserve, premature ovarian failure, partial Asselman's syndrome, and repeated IVF failure due to the thin refractory endometrium. And in the male infertility, it is can address the oligospermia and erectile dysfunction in a male partner. So now these two issues, though egg donation and surrogacy can address as a solution for the most difficult these issues like low ovarian function and poor endometrium, but not all patients see them as acceptable due to their community myths or they want their own biological child. And many of the times, these couples are not able to afford the third party reproduction. So now, the what is the PRP? So PRP composition, because it's from our own blood. So these have the higher concentration of the cytokines and different types of growth factors as below. So these growth factors are commonly more prominent are 8 known growth factors. They are platelets derived, insulin-like, fibroblasts, epithelial growth factor, vascular endothelial, transforming, and cytokines like, and hepatocyte growth factor. And hepatocyte growth factors is again very important. It is angiogenesis stimulator. And in addition to the growth factors and cytokines, platelets PRP also having like adhesion molecules such as fibronectin, vitronectin, and sphingosine 1 phosphate, which initiate tissue repair and wound healing. So that the next step is, how does PRP work? The theory underlying this treatment modality has been derived from natural healing process, as the body first response to tissue injury is to deliver platelets to the injured area. In day-to-day life, we all must, I believe, I'm sure rather, we all have experienced this miraculous substance many times at work in form of yellow substance that forms over a cut whenever we get during the work, knowingly or unknowingly. And it's a combination clotted blood, white blood cells, platelet, and growth factors to stop bleeding, act to defend against infection, and gradually it does regeneration by forming new skin, blood vessels, and connective tissue. The platelets promotes healing and attract stem cells to the site of injury by chemotaxis. That is, what is chemotaxis? That is the directional movement in response to a chemical stimulus. Whenever there is an injury or a cut on the body, there is a This substance is directed by the chemical stimulus. So, moving from basic science to clinical practice, PRP injections have been applied to diseased area. Malti, I'll say the next, then you change. So procedure of PRP preparation. So we are already on this slide. It is prepared through though there is not much consensus about the preparation, but I do make this by through a process known as differential centrifugation, which separates the component of blood based on different specific gravity as shown below. So first we draw the blood-wise skull when set number 18 directly into the glass tube containing anticoagulant. The ratio of the anticoagulant must be 1 ml to 9 ml of blood. It should be maintained ideally like that. And centrifuge for 15 minutes at 1500 rpm. And then the plasma-rich platelets, as shown in this glass tube, they separated on the top. So that's a supernet is the plasma rich in the platelets. They are taken to the other glass tube by a sterile pipette for the next hard spin at 3500 rpm to get the platelet pellet. Again, this is done at 3500 rpm for 15 minutes. Procedures are very important. Then this PRP, the supernet is having the, after second spin, having the platelet poor plasma. So whatever we want a required amount of the PRP, like suppose if we have to inject in the one ovary, we leave 0.5 ml this fluid. If we need to inject in both the ovaries, we leave 1 ml of the fluid. So leaving behind only 1 ml of the fluid, the supernet is taken by the sterile pipette and it is discarded. Then there's a formed pellet is suspended in the fluid using a sterile pipette. Now with another sterile pipette, this gently pellet is the mix in the fluid for the injection.
डॉक्टर रेखा गुप्ता आप स्लाइड्स शेयर कर रहे हैं, प्लीज बंद कर दीजिए.
Then we also have two methods. One thought of the school, they trigger this growth this why trigger the growth factors, and other they don't. So I do. Hello, ma'am.
Malti is going to present because बीच में डॉक्टर रेखा गुप्ता ने प्रेजेंट करना शुरू कर दिया. Okay, you go ahead.
So method I do use the trigger for growth factor. So different platelets activator triggers the release of these growth factors. There are a variety of substances used to trigger as thrombin, calcium chloride, collagen, and also latest we are doing with the freezing with the liquid nitrogen. So I'm using both calcium chloride and sometimes freezing with the liquid nitrogen. So each method influences both the physical form of PRP and the amount of growth factor release as well as the kinetics of release. So since there is no evidence has been found regarding the ideal concentration and type of activator required to trigger the optimal release of growth factors during the activation process of PRP. So different substances as the trigger to be are being used. So different concentration of the PRP they are getting. So therefore this lead to different results. So this is the main reason to say why few are very happy with this PRP therapy and few are just think it's just hype. So nothing else. So because there is no standardized way of the treatment, there is no consensus for the making of the treatment. So many people they make this solution only by one centrifugation, and they don't get the required growth factor. So now this prepared PRP injection for ovarian rejuvenation is injected directly into the ovarian stroma for renewed fertility by two techniques I do. One is TVS guided PRP injection into the ovarian stroma. As we do in IVF, we take the do the OPU, ovum pickup. And the other one, during laparoscopy, I don't have much guts. I just do the opportunistic procedure when I'm doing laparoscopy for any other procedure. In that case, I do by explaining the patient. Otherwise, solely for the injection of the PRP, I have not started in the laparoscopy procedure. So pre-procedure instructions for the patient to make sure to drink plenty of water, which assists to draw adequate quantity of blood, and 50 to 25 minutes brisk exercise, as literature suggests, it increases the growth quantity of growth factors. And before that, we also have to stop anti-inflammatory drugs at least 2 days prior to PRP sample, and do not advise in post-operative period also, and withdraw blood thinners if patient is on the blood thinner at least 24 to 48 hours before collection of sample, which may be resumed after collection of the sample. So this is the this you can play this video, this animation. Malti, you can play. This is the way as YTVS transvaginal sonography we do inject. So on the next slide, aims of PRP injections. Primarily aim of injected PRP for ovarian rejuvenation is resumption of menses and improvement in hormonal levels towards normal range. As ovarian rejuvenation, we know it's a procedure that may create new eggs in the dormant ovaries. That is in women whose ovaries have stopped producing eggs due to the reduced ovarian reserve or premature ovarian failure. So what are the prerequisites for doing the PRP injection? The basic routine investigation has to be carried out, like the CVC, grouping, and blood sugar urine. And markers, basic markers, they too should be done. FSH, E2, AMH, and AFC. AMH and AFC are supposed to be the best marker for the assessment of the ovarian reserve. Why they are being done? Because in the initially, just to know the status of the ovarian reserve of the patient, and later on for the comparison, how much improved she has got after the PRP therapy. And also she should be nil orally like other operation, because the GA is being given for at least 8 hours before undergoing this procedure. So ideal candidates for ovarian rejuvenation, it is recommended for women with secondary amenorrhea for at least 3 months, and infertile women having low ovarian reserve only just because of the ovarian dysfunction is being given. So time when to inject the PRP is again a question for ovarian rejuvenation. So in amenorrheic women, the procedure can be performed at any time, but in menstruating women, the procedure is best performed early in the cycle prior to the development of an egg follicle. After injection, follow-up is done, is a very important part. If there is rise of AMS level and decline in FSH level, it is a positive sign to predict that the ovarian rejuvenation is working. The improvement may take 3 to 6 months of time. Since this type of tissue transformation takes time and every patient's situation is different, all patients are not of the same profile. So once a patient begin to ovulate, IUI can be done, eggs can be collected for IVF, ICSI, and can be freezed for later use. So this is again, Malti, you can play. This is animation I have taken where the few people are doing only one shot of the centrifugation. After follow-up, Malti, you can play this video of animation. Just to refresh, revise the beginners one they want to do. Just withdraw the blood. Centrifugation is done. So now the different types of reagent is coming. So few people are doing started doing only one spinning, not double centrifugation. Now I come the second part of the like female issue for the infertility. That is the thin endometrium is among the important cause of cycle cancellation in assisted reproductive technology. So strategy to improve the thin endometrium are many we tried in our practice. There's a low dose aspirin, pentoxifylline, vitamin E, sildenafil. That's a better to say basket of the like the products. Estrogen, GCSF, but no, we can't say not all cases have benefited, but rather sometimes we get the effect. It depends on the patient, but usually we don't get the effect. Till last year GCSF was very popularized, but still now it's not giving good results. So prepared PRP is pushed into the endometrial junction and the needle is withdrawn under vision to prevent leakage of injected fluid on withdrawal of the needle. So PRP has to be given in 20 to 30 minutes after preparation and very slowly. This is like a article I have taken. It's a pilot study done by Agarwal and all. So they had done like directly prepared endometrium. They have instilled by the IUI cannula into the endometrium, and they have also instilled it by the hysteroscopically. So this actually I edited my video. So Malti, next video you can start. This is I make some try to make some like holes in the endometrium and pushed instill the like a PRP and also anteriorly, posteriorly and both lateral walls. Next, so they with the pilot study, the result is like this. They found normally there is the implantation in the normal patient. When the endometrium is poor, there is no implantation, and after the PRP therapy, the implantation is improved. The next slide, Malti. So this is showing that on the top, the first there's a normal patient with the healthy endometrium. The second row is the poor endometrium. There is no implantation. And third row of this pilot study is after the PRP therapy, where the implantation improved and clinical pregnancy also found in these cases. So again, they are like a research article I found on the net. In this also, the autologous platelet-rich plasma on was done for the endometrial expansion in patient undergoing frozen thaw embryo treatment. A double-blind study. It meant like 72 patients they had taken of the cancelled frozen thaw embryo transfer cycle due to the thin endometrium. And the concluding was they found a better result after the PRP therapy. Initially, before injection, the thickness of the endometrium was 4.92. Later on, and the first intervention, it became 5.993. And after second intervention, it could grow up to 7. And later on, they found in this case improved implantation and also they documented the clinical pregnancy. There are also other many studies, though there is a lack of the controlled trials. So studies are one more study autologous infusion in cases of thin endometrium, in which these like Kim et al. Chang, they had done the prospective intervention in the thin and poor endometrium. And Iftikhar, they had done the randomized clinical trial, but it was small, only on the 40 patients. And also Wing et al., they had done the prospective interventional study. So they all concluded that there is a improvement by the PRP therapy, and it's a work is a promising result in the failed implantation failure to get the clinical pregnancy. One more study of autologous platelet plasma infusion case of refractory endometrium. The study design, the population, it is the study of 2015, quite, old study of the Cheng et al. And the other Molina, Tendulwar and Jeng et al. The conclusion is the same. They found a promising result by using the PRP therapy for the thin refractory endometrium. So PRP for repeated implantation failure. Nazir et al. Included 20 women with history of RAF, recurrent implantation failure. They evaluated the effectiveness of PRP in increasing the pregnancy rate in RIF patients. After applying exclusion criteria, which were uterine, chromosomal, and genetic abnormality, and there were also disorder of the hematology, immunological, and hormonal, and inclusion criteria with age below 40 years and body mass index below 30. They reported that 18 of their 20 participants, that is 90%, became pregnant, and 16 clinical pregnancies were recorded, and their pregnancies were ongoing at the time of the study. And there was also, out of these, one molar pregnancy and one miscarriage. So their conclusion were PRP was an effective method in improving pregnancy outcome in RIF patients. So advantage of PRP is less invasive, it's a safe, less time taken, and improved pregnancy rates. So managing male infertility by PRP. So I don't have much experience about this, but I have taken the studies on that. For the oligospermia, that is the low sperm count, and for erectile dysfunction. So injection of PRP for the oligospermia, they have noted it should be done in the seminiferous tubules of testes, and for erectile dysfunction should be given in corpora cavernosa. The follow-up done after 90 days by basic semen analysis. So semen analysis is quite easy, so nothing to worry about this. So can be done twice, thrice to check the improvement. The success rate is up to 60% in these two problems. The post-operative care is bed rest for 1 day, avoidance of any load-bearing activities for at least 2 weeks following the procedure, need to refrain from taking non-steroidal anti-inflammatory for 4 weeks before and after, promote release of serotonin, dopamine, being happy and positive, and these all help, and taking natural antioxidant, fish oil, and turmeric, giloy, all these additives give a good result. So what are the benefits of the PRP therapy? The greatest possible benefit is chance to become pregnant using one's own eggs, no risk of blood-borne viral infections such as HIV or hepatitis. There's a contraindication of PRP, heavy smoking, alcoholic platelet dysfunction syndromes, thrombocytopenia, hyperfibrinogenemia, hemodynamics instability, the chronic liver disease, anticoagulation therapy. The tips for success of PRP. So one thing is a very important. We should before taking the sample of the patient so we should really do the CVC. We should check what is the status of the platelets of the patient. If already they are lesser in amount, your patient has suffered, good history should be taking dengue. So her platelets is already very down. So we should not try in these patients. So pre-preparation, good count of platelets, that should be at least 1.5 million. And activation of PRP is my experience prior to inject should be done with calcium chloride or by liquid nitrogen. Now with the liquid nitrogen also we are getting good result in disruption of the growth factor. Avoidance of the NSAID already is very important, and close monitoring and maintenance of the sterilization. Regular cross-checking of the platelets value is a must to obtain a consistent result. So way forward, our goal should be to find a safe, simple, standardized PRP preparation protocol to obtain the best stable platelet yield and clinical result. Since PRP is from our own body, so hence it does not require a FDA approval. Conclusion: autologous PRP is a novel approach for improving the ET and increasing pregnancy rate of infertile women with thin refractory endometrium. Since PRP is obtained from the patient's own blood, there's no risk of any infection. Moreover, since it is easily available, inexpensive, and involves local administration, it can prove to be a boon for the infertile patient. To use PRP, further research in the form of large-scale randomized controlled trial needed. So next is, like, suppose in 1978, when the birth of this baby Louis one, nobody could think at that time it was just a miracle of the birth of this baby. Nobody could think that today we are in the era, the IVF is the practice of every clinic. Every patient, infertile patient, after some trial asking for the IVF. So nothing is impossible. The PRP is the like success from our own blood. And today we are in the era of the space when the Bikram has landed in the space. So why not? PRP may be the future of our many diseases. For them, we don't have any solution, permanent solution. And they have so many recurrence, like so problems like diabetes, hypertensive, infertility. So why not? We can create miracles by PRP, give hope to the hopeless, rewrite medical science. And thank you so much, everyone, for patiently listening. And from the my folded hand with the heart to Sharda ma'am for giving me this opportunity. I'm really very sorry for so much inconvenience. I'm really feeling very sad. I don't know, every time it happens with me. Sometimes Wi-Fi runs away, sometimes pen drive is lost. I don't know, something wrong with me. So even my sisters are sitting here, they are feeling sad to create so much of nuisance. So thank you so much, everyone, for listening and giving me this
Thank you, Dr.
opportunity.
Tarini. Thank you for the nice talk. And now I invite Madam for her expert opinion.
I think her deliberation had been absolutely wonderful. As far as thin endometrium is concerned, I think I've been using it and I find it very satisfactory, provided with GCF and estrogen valerate we reach to at least 6. So then I find, this was effective. If the endometrium does not pick up with these measures, though sometimes only it fails, but I think you need to find out the cause. As for the ovarian rejuvenation is concerned, I think, I will still call it experimental. And I'm not sure with PRP, the people, I will advocate it should be bone marrow processed and then it should be injected then laparoscopically route. I will take the opinion of other people.
शंकर एक मिनट रुक जाना.
There are many people are here. Take their expert opinions.
Unmute yourself, Dr. Poonam.
Dr. Jyoti Malik.
Thank you so much. Thank you, Dr. Sharda Jain, ma'am, Dr. Poonam, and Dr. Tarini for giving me the opportunity. And Dr. Tarini, it was a wonderful talk. I have been using PRP both for endometrial, for thin endometrium, and also for ovarian rejuvenation in cases of poor ovarian reserve. I have done at least only 2 cases by laparoscopically injecting PRP into the ovaries, and that was specifically in cases where the patient never wanted a oocyte donation and we had no other choice. And the second is, once I have also tried doing it transvaginal by a TVS approach, But since the ovaries are very small, it is very, very difficult to go into those ovaries. So next time what I did was I just gave letrozole to that patient. And around mid cycle जब मुझे थोड़ा सा एक दो फॉलिकल दिखना शुरू हुआ तो मुझे समझ में आया कि ये ओवरी है. And then I tried to inject that PRP via TVS approach under under short GA or a deep sedation that way. So I tried you putting both ways, laparoscopic as well as TVS. Both have their pros and cons, and depending on which particular route you are comfortable, because with the TVS it is difficult to spot those small ovaries. And for the thin endometrium, sometimes we just instill, like we do IUI, very slowly, just instill drop by drop, very slowly, like a IUI. But better is to put subendometrial via hysteroscopic approach so that it goes just below the endometrium. Below the endometrium, by same, we use the same needle of the pickup needle, and through the side channel we put that needle, and I just put it subendometrial under on the anterior and posterior walls, and also side walls, both side walls. So it has been done. The endometrium does improve. Fertility, whether it improves, whether we get live birth rate and all, it is very early to state that.
But Dr. Tarini, I would like to ask that after doing this, have you seen any increase in AMH? Have that been noted?
Dr. Poonam, actually, you will be really surprised. I'm doing for the last 10 years. And still, I have so many like testimonials. मेरा ये चला नहीं. So, only one patient I have, because I'm very irregular in OPD. Delivered, and I have got the like their follicles are there. The one patient, there was this amenorrhea of 7 years, and I have testimonials in the laptop also. So she's very happy. She took 3 cycles, and she started like menstruating. Now she came for the treatment of infertility. So again she demanded कि मैम मेरे को वही दवाई आप ब्लड से बना के डाल दो, और उसका लिटरली इट वाज मे बी द हर फेथ एंड ट्रस्ट. तो उसको फॉलिकल्स बन गया है. नाउ शी इज इन द प्रोसेस. It was the like 10th day when I left her 2 days back. Today I'm in Delhi. She's the patient from Muzaffarnagar. So, I'm getting good result. And Dr. Taneja to doing left and right in the like after operation in the ear, and they are getting the better healing in the whatever he does in the patching of the ear, this membrane in the whole of the ear. जब बन जाता है उसमें he is doing tympanoplasty. So he is getting very, very good result. So I don't know, I'm really surprised
I
because
think
मैं
Dr.
सारे patient को
Poonam,
नहीं
I have
करती.
also heard, I think I've heard my friend Dr. Rimi Singla is there in Chandigarh. She's also using PRP. And in fact, one or two papers that she has, not a paper that she's presented, but in some seminar she showed that she got very good follicles after this, and even her the AMH improved, and the number of follicles that could be retrieved in the second cycle was much better. So people have been giving favorable thoughts to this.
It depends on the basic status of the platelets. Kitna hai, how you are making, are you able to trigger or not trigger? These all are questions.
Dr. Seema, your experience?
How do you activate it? Dr. Tarini, how do you activate the platelets? What activating factor? When do you put? How much
I'm
you put?
using
At
with
what
the
time you put?
when I prepared the PRP, when everything has done, pellet has been suspended, so I take the injection in that needle, whatever I'm doing, like for the endometrium or ovarian. Then I add that's a 1 ml of calcium chloride. Now recently I've started in the like putting in the thermocol box having the nitrous liquid nitrogen. वो हमारे पास होता ही है for the cryo. So liquid nitrogen for the like tip for like to say hardly for 1 minute. Then I thaw in between my palms for 3 times. That's a my norm, and I find it's better for the like a disruption of the this uh, products like growth factors. So the better growth factor, better result you get. So the selection of patient is very, very important. Also individualization for which patient you are doing TVS, for which patient you are doing laparoscopically. I don't have so much of guts कि भैया मैं तुम्हारा I will do laparoscopically और fail हो जाएगा, she will eat my head. और जिसको करना है adhesions है ऐसा some other problem, then in that case I put the get the result also.
And what kit you are using? Which company's kit you are using for that?
जैसा एक्चुअली मुझे नहीं, ये तो मंगा के देता, मेरा बेटा भी करता है ना कॉस्मेटिक तो इन लोग मंगाते, पहले हम सैगल से मंगाते थे, नाउ आई डोंट नो, डॉक्टर साहब किसी और से अहमदाबाद से कांटेक्ट करते मंगाते हैं और बेटा मंगाता ऑनलाइन। वो इस हेड ये भी करता है ना हेयर ट्रांसप्लांट और फेस पे भी, तो उसका भी अच्छा रिजल्ट आता है इसका राइनोप्लास्टी का। अभी भी नीचे गया, वो लेने ही गया, अभी ही वाज गेटिंग इरिटेट कि मुझे तुम विदहेल्ड कर रहे हो अपनी इसमें लैपटॉप में, मेरा वो बैठा हुआ है एजेंट, तो शायद अभी आया हुआ है वो। सो ऑनलाइन आ रहा है आजकल,
I think
काफी यूज हो रहा है हमारे यहाँ।
we are debating it. I think endometrium is okay, but as far as ovarian rejuvenation is concerned, I have yet to find people having a pregnancies, because I think it has to be an authentic paper, something of this particular kind. Otherwise, it is it to my mind, we have had a lot of experience in stem cells, and I feel that we've tried it in many of the African doctors, not this Afghanis doctors, but in none of patients कोई कहे AMH बढ़ गया और follicles आ गए और pregnancy आ गई। ये मुझे थोड़ा सा digest करने में थोड़ा मुश्किल लग रहा है। अगर if it is so, then we will start sending cases to you.
मैम एक्चुअली आपको कभी आएगी पेशेंट अभी तो वीडियो कॉल कराऊंगी। Patients are coming because we don't have the like trial studies that we need. There are so many other like big clinic is doing. They are not documenting. There's not much control trial, but one day will come when we will accept it.
डॉक्टर सीमा आप कुछ कह रहे थे?
Thank you very much, and Dr. Tarini, excellent, because your patient became pregnant. That was really good news. I think we all should work toward that. But according to me, we are using only in thin endometrium. Once I used laparoscopically for a patient, she was elderly and she wanted her own eggs, but I think there was no result. It is just a eye wash. We said we have done everything for you, and that was the thing. But for yes, endometrium, I'm happy using PRP. But for ovarian rejuvenation, I think stem cells are better than PRP. What my take on, because they work better.
Dr. Shivani, your experience? Dr. Shivani God? हाँ शिवानी।
Ma'am, I am using PRP and stem cells both for endometrium and for thin endometrium. So it is phenomenal, fantastic. Like patients with no hope. I have a patient now pregnant, 3 centimeter uterus, only just like the tip of the instrument, jitna uterus, who is pregnant. And as for ovarian, definitely AMH improves because we do PRP, we send the patient. वो अपनी country में अपना AMH कराते हैं. When the AMH improves, they come back. So इसके लिए definitely there is some beneficial effect. But yeah, it is like very patchy. It is not uniform.
But Dr. Shivani, you are using stem cells or PRP for that? Ovarian.
Combination. Dr. Sunita Arora ने जब से paper publish किया है तब से मैं combination use कर रही हूँ दोनों का.
And what's a combination in form of?
Means both PRP and stem cells. And the concept is ovarian injury. So you have to puncture many times and inject.
And there's any amount of like any ml which has to be injected?
Very less, because I have had complication also. I had patients जिसका बाद में hemorrhagic cyst भी बन गया था, adhesion बन गए PRP के बाद, stem cell के बाद. So you have to use very small quantities.
Yeah, we have used just 0.2 ml, but that remains in the, you can say
exactly. So you need to know the trick, how to get it out of the needle and how to use combination. And these are small slippery ovaries. So laparoscopy में कैसे करना है? So you need that expertise.
Okay. We can hold the ovaries, that is no problem. And the point also we can, but yes, take out that 0.2 ml from
हो
the syringe.
सकता है मैम पीछे एयर इंजेक्ट करना होता है और आपको अपना वो मेजर करके देखना होता है तो उसके हिसाब से हो जाता है जो बचता है पीआरपी यू कैन यूज इट लेटर फॉर अदर ओवरी और यू कैन यूज इट इन द यूट्रस आल्सो तो स्टेम सेल और पीआरपी दोनों का कॉम्बिनेशन यूज करते हैं
Seema, actually, to put inside it is not difficult. To make her pregnant is difficult.
That's true.
हमारे को एमएच बढ़ गया या फॉलिकल बढ़ गया उससे कुछ नहीं होता. प्रेगनेंसी हो तो बताओ भाई और होगी तो हम आपके पास 100 केसेस भेजेंगे.
So let us move to our next topic for today. Dr. Shikha Jain from Dreams IVF. She will be presenting Surrogacy Act 2021. What should we know? Dr. Shikha, please make it full screen.